Welcome to the lecture entitled The Viscera. My name is Carlos Andres Suarez-Quian. I am the creator and the narrator of this lecture. Let's begin. The objective of this lecture is simply to present a survey of the organs found in the abdominal cavity and to detail their pertinent features. Additional details relevant to these organs will be presented in subsequent lectures. Having defined the peritoneal cavity and the definition of an intra versus a retroperitoneal organ in the previous lecture, now it is time to discuss the visceral organs. Here, I show you the abdominal organs with a greater omentum in place on the left panel and with the greater omentum reflected on the right panel. First, I will label the readily visible organs on the left panel and next on the right panel. These are fairly standard images of what one sees when entering the cadaveric abdomen. Here's another example of visceral organs in a cadaver. On the left panel, everything looks sort of as before, but note the green liver and how large it is compared to the previous one. It is completely masking the stomach. After reflecting the greater omentum, the right panel, I can again label the obvious organs, but now note the pale white gallbladder. I show these two examples to emphasize that when examining the abdominal content of a cadaver, it is most unlikely that you will see what is shown to you in textbooks. Expect variations, especially due to significant pathology. By the way, this cadaver had a complete blockage of its hepatic ducts and bile could not exit the liver. However, there were no stones that we could find in the gallbladder. Before continuing, let me present a drawing of the organs, something you're more likely to be familiar with. I will label the organs we will discuss in more detail as the lecture proceeds. I start with the distal end of the esophagus that pierces the diaphragm and delivers its content to the stomach. Behind the stomach is the spleen, an organ of the lymphatic system. Food in the stomach will pass to the duodenum, the first part of the small intestine. The liver and gallbladder will deliver the contents to the duodenum via the bile duct. In addition, the pancreas will also secrete enzymes into the duodenum via the main pancreatic duct. Continuing with the small intestines, the jejunum and ileum make up the remaining parts of the small intestines. The small intestines empty into the large intestines at the cecum, the beginning of the large intestines. The appendix is found near the ileocecal juncture. The different parts of the large intestines consist of the ascending colon, the transverse colon, the descending colon, the sigmoid colon, the rectum, and the upper portion of the anus. Based on their development, these organs are grouped together into the foregut, midgut, or hindgut. The foregut consists of the organs beginning with the distal esophagus to midway of the duodenum. From this point to approximately 2/3 of the transverse colon represents the midgut. From the transverse colon to the upper anus is the hindgut. Each division will be supplied principally by one artery. We will see these later. Having identified the basic abdominal organs, I now present what we need to know about each. Here are the 5 questions a beginning student should pose themselves and answer with respect to each abdominal organ. What is it? Where is it? What is the surface anatomy of the organ? What are the relationships of the organ? That is, what is anterior, posterior, left, and right of the organ, and finally, what is its plumbing? That is, the arterial supply, the venous drainage, and especially the lymphatics of the organ. At this point, we discuss each organ individually and start with the stomach as an example of how to study the abdominal organs. What is the stomach? The stomach is the most dilated part of the gastrointestinal tract. Its shape can vary, but generally it is a J shape. The principal function of the stomach is to receive food from the esophagus and break it down in order for food digestion to occur. It secretes numerous enzymes, including pepsin, an enzyme that helps to break down proteins into smaller fragments. The acid secretion by the stomach also helps to break down proteins, as well as preventing development of infections from ingested bacteria. Additionally, the stomach consists of 4 distinct portions. They include the cardia that surrounds the superior opening of the stomach, the fundus, the rounded, often gas-filled portion superior to and left of the cardia, the body, the large central portion inferior to the fundus, and the pylorus. This area connects the stomach to the duodenum. It is divided into the pyloric antrum, pyloric canal, and pyloric sphincter, structures important to gastroenterologists. The transpyloric plane is approximately at the level of L1. The medial and lateral borders of the stomach are curved, forming the greater curvatures and the lesser curvature. Recall that the greater omentum hangs from the greater curvature and the lesser omentum joins the stomach to the liver. In addition, 2 features of the stomach curvatures must be noted: the cardiac notch, the superior angle created when the esophagus enters the stomach, and the angular incisure, the bend of the lesser curvature. Where's the stomach? Here, I've superimposed a rib cage and the imaginary lines used by anatomists to subdivide the abdomen. As a review, these lines include the midclavicular lines and the transpyloric plane. The transtubular plane is below the range of the image and is not included here. In the image, it is possible to see the defined spaces that the stomach occupies. These regions will include the epigastric, the left hypochondrium, and the umbilical. However, expect small variations, as is obvious in the image. I next answer what is the surface anatomy of the stomach. I superimpose skin on the thorax and abdominal content, but I think you can still make out the approximate outline of the stomach. Again, the stomach projects to the epigastric, the left hypochondrium, and the umbilical regions. Specifically, however, the stomach does not project precisely to the umbilicus. Indeed, when a child complains of a bellyache and places their hand on the umbilicus, they're likely sensing bloating of the small intestines, precisely not the stomach itself. The stomach is nowhere near where the child is pointing to. Moving to the relationships of the stomach, I show this dissection that you have seen previously. The upper border of the abdomen, the diaphragm, is labeled, as are the liver, the gallbladder, and the greater omentum. The anterior abdominal wall was removed much earlier, but it's still there. The stomach is now also indicated. All these structures named are considered to be anterior relationships of the stomach. However, if you want to see more additional relationships of the stomach, the liver must be retracted out of the way. Now, the superior relationships of the stomach can be appreciated, namely the esophagus and the left dome of the diaphragm. To find the posterior relationships of the stomach is more tricky. One has to remove the stomach from the cadaver and look behind it, or, as is the case here, remove the complete viscera, keep it aligned, and then look at the organs posterior to the stomach. Given that this is a posterior view, I label the right and left sides for orientation. Now, let's label the liver and the stomach. I can also label the esophagus to confirm the superior direction. Now, let's start labeling the structures located posterior to the stomach. The spleen and the pancreas are evident. If you truly understand the arrangement of the peritoneum in the abdomen, then you must also realize that the lesser sac is a posterior relationship of the stomach. Finally, the important splenic artery and vein are also posterior relationships of the stomach. Using this approach of showing the viscera from behind, however, does not demonstrate all that is anatomically located behind the stomach. To see further, I have to show you what previous anatomists did to explore relationships. They cut the body into actual sections as are now shown in the image. Both sections are presented in the conventional way. So let me add directions: anterior, posterior, right, and left. The image to the left is superior to the one on the right. I now label the liver and spleen for orientation, and the stomach, the organ of interest. It is now possible to label the two major organs located posterior to the stomach that I have not mentioned, the kidney and the left suprarenal. As you can probably surmise, understanding relationships is vital to the abdominal surgeon. When making a cut, they must know what may be possibly injured if they go too deep. The last question to answer for the stomach is its plumbing. Where do arteries arise that feed the stomach, the veins that drain it, and the lymphatics that help remove the lymph fluid? Let me show you first a schematic drawing of the blood supply of the stomach before I show you an actual dissection. The aorta is now labeled, and the artery of the foregut, the celiac trunk. 3 arteries arise from the celiac trunk, and all will ultimately provide arterial supply to the stomach. These arteries are the left gastric, the splenic, and the common hepatic. The splenic travels posterior to the stomach and then sends short branches to the fundus of the greater curvature of the stomach. In addition, the splenic will supply the greater curvature of the stomach by way of the left gastromental artery. The common hepatic was split into a hepatic artery proper and a gastroduodenal artery. The gastroduodenal travels behind the pylorus and branches into the right gastromental artery that will send short branches to the stomach and into pancreatic branches. From the hepatic artery proper, a right gastric artery emerges. Although beginning students make the assumption that the arterial branches to the stomach provide blood solely to specific regions, this is not the case. There is tremendous redundancy in the areas supplied by the branches. Compromising the right gastromental artery, for example, will not necessarily lead to stomach necrosis. There are ample anastomoses with other branches to compensate. I should mention here that if you know the arteries, you also know the veins. Veins will simply be present alongside the arteries. These veins, however, are all part of the portal system of veins and will drain to the portal vein. We will see this later. Same for the lymphatic vessels. They will drain to the cisterna chyli. The autonomic nerves supply the stomach. Parasympathetics are provided from the vagus, whereas the sympathetic nerves arise from the greater splanchnic nerve. The autonomics use the arteries to reach the stomach. The schematic presented in the previous slide is a realistic representation of the arterial supply of the stomach. Look at the dissection shown here and note how similar the two images are. Of course, significant variations in the vascularization of the stomach exist and have been reported. For the most part, however, branches from the celiac trunk are relatively standard. Note that in the dissection, the aorta is not yet exposed, but the portal vein, the vein to which the veins of the stomach ultimately drain to, is present. Clearly, there is much to learn about each individual organ. I've used the stomach as a model of how general surgeons expect their students to learn the details of individual organs. Indeed, this is only the beginning of what a general surgeon learns as part of their residency program. Going forward, I will streamline the information needed to learn for the remaining organs of the abdomen. The stomach empties its contents into the small intestines, specifically the first part of the duodenum, which we can see in the image. The function of the duodenum is to secrete large amounts of mucus to protect the small intestines from the strongly acidic chyme and the acids secreted in the stomach to break down proteins. We now zoom in on this first part of the duodenum and again distinguish the stomach from the first part of the duodenum. In reality, the duodenum is a C-shaped structure that cradles the head of the pancreas. In this image, the duodenum was partially depressed to expose the pancreas. What is clear, however, is that the rest of the duodenum is not visible. The first part of the duodenum, seen here, is intraperitoneal, whereas most of the rest is retroperitoneal. To find the retroperitoneal portion of the duodenum, we need to reflect the greater omentum and stomach superiorly, which leads to a confusing image. Let me label the structures to try and clarify what is happening now. Here's the reflected stomach. Given that the greater omentum was reflected superiorly, the rest of the small intestines are now exposed. The C-shaped duodenum has now been colorized and labeled. The head of the pancreas, cradled by the duodenum, is readily identified. To truly appreciate the C-shaped duodenum, it is best to eviscerate the abdominal organs and to look at the duodenum from behind. This is now being shown in the image. I am labeling the liver, stomach, and spleen for orientation. The C-shaped duodenum is now colorized and labeled. Note how the head of the pancreas is truly cradled by the duodenum. I now want you to again focus on the first part of the duodenum as it is shown from the front and from the back. I now indicate the gastroduodenal artery viewed from both directions. The reason to point out this relationship between the first part of the duodenum and the gastroduodenal artery is that most ulcers occur here. If the ulcer eventually perforates the wall of the duodenum, the escaping acids are quite likely to erode the wall of the gastroduodenal artery, leading to a massive abdominal hemorrhage. Death of patients is a likely outcome even today. If we now look at the second part of the duodenum, the part that descends, two structures can be observed to enter it. One is a bile duct that delivers bile to it from the gallbladder and liver once fats enter the duodenum. The bile helps to emulsify the ingested fats. Think ice cream. The second structure is a pancreatic duct, the duct that delivers pancreatic enzymes into the duodenum, but not insulin. Insulin is an endocrine hormone. Insulin is secreted into the blood system. If we focus now on the spot where the bile and pancreatic ducts open and cut open the second part of the duodenum, as shown on the right panel, the duodenal papilla of Vata is illustrated. Microscopically, a sphincter surrounds the papilla, the sphincter of Oddi. And no, the papilla and sphincter were not named for Jedi Masters Darth Vader and Obi-Wan Kenobi, but it is where a gastroenterologist seeks to drive their endoscope to examine the bile duct in a procedure termed cholangiography. Considering the third and fourth parts of the duodenum, important landmarks serve to identify their locations. Looking at the duodenum from the front, on the left panel, the superior mesenteric artery and vein cross just anterior to the third part of the duodenum. Looking at the duodenum from the back, the fourth part rises and is attached to the back of the abdomen by a ligament, the suspensory ligament of Treitz. Although the ligament was cut to eviscerate the body, clinically, surgeons use it to identify the boundary between the duodenum and the second part of the small intestine, the jejunum. Continuous with the duodenum are the jejunum and ileum, the continuation of the small intestines. If you're wondering if you can distinguish the difference between the two with the naked eye, the answer is no. More details are needed to differentiate between the jejunum and the ileum. However, a surgeon can always go to the location of the ligament of Treitz and then proceed from there to the next part of the small intestine. This would be the jejunum. At the other end, one can find the beginning of the large intestine, the cecum, and proceed proximally. This would be the ileum. In addition, fatty material is evident within the small intestines, and this material represents the mesentery, which supports and provides the highways for the neurovascular bundles to supply the small intestines. Look closely to distinguish between the mesentery and the greater omentum, which in this dissection is reflected upwards along exposure of the large intestines. The blood supply to the small intestine is from the superior mesenteric artery, shown here in a dissection. Recall that this artery emerged from the aorta, not yet visualized in the dissection, anterior to the third part of the duodenum. Emerging from the left side of the superior mesenteric artery are several branches termed jejunal ileal branches. As to which is a jejunal or an ileal branch, as with the parts of the small intestines, it is difficult to tell simply by looking at them. However, if one carefully peels back the mesentery, then it becomes possible to distinguish between the jejunum and the ileum with the naked eye, simply by examining the vasculature that feeds the two parts of the small intestines. This is now demonstrated in the dissection. In the jejunum, the vasa recta are longer than those in the ileum. The arterial arcades are more numerous in the ileum than in the jejunum. As to the principal surface projection of the small intestines, they may be found in all compartments of the abdomen, although they tend to be principally within the umbilical and pubic compartments. They range from 6 to 7 meters long. They are at the site where most of the digestion of food occurs and where most absorption of the digested food takes place. The large intestines extend from the small intestines to the anus. The large intestines are also known as the colon, now indicated in the dissection. Understand why it is called the large intestine. Its diameter is greater than that of the small intestines. Note that when we first expose the abdominal organs by reflecting the greater omentum, as in this dissection, the more distal parts of the large intestines are not visible. In this dissection, the visible components include the cecum, or blind pouch, hence its name, the beginning of the large intestines, the ascending colon, the right colic flexure, the transverse colon, the left colic flexure, and the descending colon. And did you miss the appendix extending from the cecum? All intestines are retracted upwards. We can see the continuation of the large intestines. These parts include the sigmoid colon and the rectum. Combining the two dissections into one setting, we can label all the different parts of the large intestines and follow them in a proximal to distal direction. Another useful exercise to do in an actual dissection is to try and move the components of the large intestines and observe which are mobile and which are fixed to the posterior abdominal wall. In so doing, it is easily possible to identify the intraperineal components from the retroperineal components of the colon. The mobility is due to the fact that the intraperitoneal components retain the dorsal mesentery in which they developed. The retroperitoneal components lost theirs. The intraperitoneal components include the appendix, the cecum, the transverse colon, the sigmoid colon, and the first part of the rectum. The retroperitoneal components are the ascending and the descending colons and the rest of the rectum and anus. The general functions of the large intestines are listed here. They include secretion of large quantities of mucus, but no digestive enzymes. Water is reabsorbed. Undigested food is stored and formed into solid waste material. Bacteria work on feces to produce vitamin K and other of the B complex vitamins, and this helps explain why systemic antibody therapy can be detrimental to overall health. The antibiotics can destroy symbiotic bacteria. Once you become familiar with the large intestines, you will come to realize that there are three key features of this organ. First, they exhibit haustra, small pouches caused by saculations which give the colon its segmented appearance. Second, they have taenia coli that run the length of the large intestine. Because the taenia coli is shorter than the intestines, the colons become sacculated between the taenia, forming the haustra. Finally, the colon exhibits appendices epiploica. These are fatty appendices protruding from the surface of the colon. Previously, I showed a similar dissection to this one and stated that the superior mesenteric artery provides blood to the small intestines. As shown here, it also provides some of the arterial blood to the large intestines, but in this case, the arteries arise from the right side of the superior mesenteric artery. From superior to inferior, the named arteries of the large intestines are the middle colic artery, the right colic artery, and the ileocolic artery. Basically, the superior mesenteric artery supplies the midgut of the individual. The remainder of the large intestine is fed by branches of the inferior mesenteric artery, the artery of the hindgut. In this dissection, The small intestines are completely reflected, and the peritoneum of the posterior abdominal wall was removed to expose the abdominal aorta. The kidneys are also visible. The inferior mesenteric artery is now labeled. This artery gives off various branches that feed the large intestines. First, there is the left colic artery, then various branches to the sigmoid colon, and finally the superior mesenteric artery ends as a superior rectal artery. I wish to point out another feature of the blood supply of the large intestine, the marginal artery of Drummond. This artery is variable, but it arises in part from branches of the superior mesenteric artery and joins branches from the inferior mesenteric artery, namely the left colic artery. The artery can serve as a collateral to the circulation of the left colic flexure. However, the left colic flexure represents a watershed area of the colon and is prone to ischemia, especially in the absence of sufficient collateral circulation. The point represents the spot where the midgut meets the hindgut. Look now at a drawing of the marginal artery of Drummond and realize the nature of the watershed and why it can be a danger spot. The middle colic artery generally only extends so far along the transverse colon. In turn, the left colic artery also can extend just so far superiorly along the descending colon. Compromising either the middle colic or left colic arteries due to pathology can and does lead to ischemia at the left colic flexure. This can lead to death of the patient if the symptoms are not recognized and treated immediately. It is not uncommon to find a necrotic descending colon in the anatomy laboratory due to such a compromise in the watershed area. Let me now move to the organs of the viscera that I only mentioned briefly. First, let me focus on the liver, the largest visceral organ in the body. It is primarily in the right hypochondrium and epigastric regions, but it can also extend to the left hypochondrium region. As you can see in the right panel, the liver is just inferior to the diaphragm and superior to the visceral organs. Thus, it is said to have a diaphragmatic surface and a visceral surface. The diaphragmatic surface is smooth and is divided into a right and left side by the falciform ligament that attaches the liver to the anterior abdominal wall. The major functions of the liver are listed here. I will not read these to you, but feel free to stop the movie and go over them. Looking at a sagittal view of the liver and its surface in a diagram, it is possible to see the close proximity of the liver to the diaphragm. Due to development of the liver within the peritoneum, two recesses are formed, the subphrenic recess and the hepatorenal recess. The subphrenic recess separates the liver from the diaphragm, and it is this surface of the diaphragm that is most absorptive and the rationale for putting patients in the Fowler position after surgery. The hepatorenal recess is continuous with the peritoneal cavity. The visceral surface is more elaborate. The porta hepatis is the entry point into the liver and consists of the hepatic arteries, the portal vein, and the exit point for the hepatic ducts. Four lobes are easily distinguished, the right and the left lobes, the right being the largest of the lobes. There is also the quadrate lobe, given its four sides, and the caudate lobe at the posterior margin of the liver. A major vessel can be observed on the posterior surface of the liver. This is the inferior vena cava. The reason it is usually present with isolated livers is that veins from the liver strain to the IVC, and during removal of the liver, the IVC is usually removed while still attached to these veins. The underside of the liver also allows us to find the gallbladder, where bile is stored and concentrated. The duct from the gallbladder to the bile duct is known as the cystic duct. Realize that bile can travel in both directions within the cystic duct, to the gallbladder and back to the bile duct, to then travel to the duodenum. Blood supply to the gallbladder is via the cystic artery, a branch from the hepatic artery proper. I will now describe the pancreas, which lies posterior to the stomach. Hence, in this dissection, the stomach has been reflected superiorly and the peritoneum of the posterior abdominal wall removed to expose the pancreas. Note that the pancreas extends from the duodenum on the right side to the spleen on the left. The functions of the pancreas include secretions of pancreatic enzymes to help digest fats, proteins, carbohydrates, and nucleic acids, to produce large amounts of alkaline fluid that helps to neutralize the chyme, and to function as an endocrine gland producing insulin and glucagon that regulate sugar metabolism. Life is incompatible without a functioning pancreas. Critical to pancreatic function is a functioning pancreatic duct. In this dissection, the head of the pancreas was carefully dissected to expose the pancreatic duct. If you recall, the pancreatic duct joins the bile duct to empty into the duodenal papilla located within the second part of the duodenum. In this dissection, the anterior wall of the duodenum was open. Given its metabolic activity and the fact that it's an endocrine organ, the blood supply of the pancreas is extensive and difficult to demonstrate in a dissection. Hence, I prepared a drawing of the general distribution of the arteries and illustrate it now. Also, although a general surgeon is required to know the precise arterial supply to the pancreas, for this course it is acceptable to know only the general distribution. At one level, both the celiac trunk and the superior mesenteric artery will give rise to arteries that supply the pancreas. The gastroduodenal artery, a branch from the common hepatic artery that in turn arises from the celiac trunk, will send several branches to the pancreas. Also, branches from the splenic artery provide significant arterial blood to the pancreas. The superior mesenteric artery will supply very small branches to the pancreas. Here, for example, I label the anterior inferior pancreaticoduodenal artery. Now you know why it is best not to describe the specific arteries of the pancreas. Their names are tongue twisters. But the vast and small numbers of these arteries help to explain why pancreatic surgery due to cancer is difficult, and why the stomach is generally detached from the duodenum and reattached to a more distal piece of the small intestine. It is practically impossible to remove a cancer growth from the pancreas and guarantee maintenance of the blood supply to the duodenum. The final organ to discuss is the spleen, shown in the drawing on the left panel and in a dissection on the right panel. Note that it is behind the stomach in the drawing, and the stomach needed to be reflected superiorly to demonstrate the spleen in the dissection. The blood supply to the spleen is from one of the three branches of the celiac trunk, the splenic artery. Note that the splenic artery is not straight, but tortuous. The vein is behind the artery and straight in this dissection, although partially hidden by the mesentery. We will see this again in a later lecture. Although as mentioned previously, the spleen is part of the lymphatic system and primarily discussed when this system is presented to students, its location within the abdominal cavity does present some clinical importance because injuries are life-threatening. As the drawing indicates, the spleen is located just below the diaphragm and well protected by the ribs. Unfortunately, blunt trauma to the area can lead to rib fractures, although the blunt trauma alone can cause spleen rupture and lead to massive hemorrhage. It is most likely of all the abdominal organs to cause a life-threatening internal bleeding event. Rib injuries were not uncommon during the days when people failed to use seat belts and front-end car collisions were common. Also, rib injuries occur in children when jumping on one another during roughhousing or in sporting events. This now concludes the presentation on the visceral organs.